Swayam Prabha. Digital India. Educated India.
The fourth lecture in the series is on arterial hypoxia or just hypoxia, where there is a reduction in partial pressure of oxygen in plasma and a reduction in oxygen saturation of hemoglobin. The context of the lecture is this. In the last session, we looked at 4 types of tissue hypoxia, 4 mechanisms which could lead to tissue hypoxia, either a reduction in cardiac output or hemoglobin concentration or oxygen saturation of hemoglobin and reduced tissue consumption of oxygen. Today we are going to look at conditions which lead to a reduction in oxygen saturation of hemoglobin, what we refer to as hypoxia. And always these two go together, a reduction in partial pressure and a reduction in oxygen saturation. The other mechanisms leading to tissue hypoxia. The definition of tissue hypoxia per se is a reduced oxygen consumption by cells. Of these 4 mechanisms, PO2 and SO2 in arterial blood are reduced only in hypoxia, and in the other 3, these 2 parameters are normal. We then considered that these states per se need not necessarily result in a reduced oxygen consumption by cells because there are compensatory mechanisms. When one goes down, the other can increase. When the compensatory mechanisms are overwhelmed, then VO2 reduces, and then we call the state as tissue hypoxia. Tissue hypoxia or a reduced VO2 resulting from hypoxia would be referred to as hypoxic hypoxia. Anemia leads to anemic hypoxia. Cardiac failure can lead to stagnant hypoxia. We even gave a mnemonic for that. And our consideration today is mechanisms of hypoxia. Hypoxia is a state where oxygen saturation in blood is low. The term hypoxia does not refer to all conditions where there is a reduction in oxygen content of arterial blood. For example, even when hemoglobin concentration is low, as in anemia, oxygen content will be low. Though saturation can be normal, a reduction in hemoglobin concentration can reduce the oxygen content of arterial blood. The term hypoxia does not refer to that. In fact, in anemia, we would say that there is no hypoxia as long as oxygen saturation is normal, even though in anemia there would be a reduction in content of arterial oxygen. In hypoxia, VO2 can still be maintained due to compensatory changes in the other terms. And if in spite of that VO2 is low, that is when tissue hypoxia occurs. Let us look at the mechanisms of hypoxia. So the syringe is here to tell you that hypoxia is diagnosed by taking a sample of arterial blood and looking at partial pressure of oxygen in it. Or it can be done non-invasively by putting a pulse oximeter on the finger, which will give you information about arterial oxygen saturation. That's how these 2 parameters are measured. We already saw that PO2 is a more sensitive index of lung function than SaO2 or SpO2, and that's why I've shown a syringe there for arterial blood gas. Hypoxia is a state where there is a problem on the lung side. The lung is not able to transfer enough oxygen to blood, and that's why PO2 and SO2 have gone down. Why would that occur? We have considered these as the broad topics in which we will have discussions, because transport in blood and cellular respiration come beyond the lung. We can take them off from our consideration. And we will ask the question, if arterial hypoxia occurs due to a ventilation defect or a perfusion defect or a diffusion defect. Ventilation is the process of inhalation and exhalation, moving air into and out of the lungs. Perfusion is the process by which blood moves through the lungs, and diffusion is a process of actual gas exchange, oxygen movement from alveolus to the blood. Which of these processes can get impaired and result in a hypoxic state is the question. Let us consider perfusion first. We've actually considered a perfusion problem under tissue hypoxia. We called it stagnant hypoxia there, cardiac failure resulting in stagnant hypoxia. And we looked at cardiac failure in the context of reduced cardiac output going to the tissues. Over time, whatever cardiac output there is from the left ventricle is what there will be from the right ventricle too. And in cardiac failure, we've already seen that arterial oxygen saturation will be normal. Among these causes of tissue hypoxia, we said in A, S and H, that is anemia, cardiac failure and histotoxic hypoxia, arterial oxygen saturation is normal, and only in hypoxic hypoxia, oxygen saturation is reduced. Therefore, because we've already considered stagnant hypoxia, which is what we are referring to as a perfusion problem in this case, we know that a reduction in cardiac output or a reduction in pulmonary blood flow is not going to result in a reduced oxygen saturation. It's obvious. When there is no problem with any of the processes here, then in cardiac failure, what happens is a reduced blood flow, but whatever blood that flows will be fully saturated with oxygen, and therefore we do not expect hypoxia in cardiac failure. Therefore, I've taken that out of our list, which leaves us with two things: a ventilation impairment and a diffusion impairment, which can result in hypoxia. To reiterate, the term hypoxia specifically refers to a state where these two parameters are less than normal. The normal values would be partial pressure of oxygen in arterial blood would be near 100, 97 or so in a reference adult male. The lowest value it could go to in such a person is 90 millimeters mercury. We will see that a little later. Oxygen saturation would be 100%, near 100%. A pulse oximeter gives you 99%, 98%. So that would be the normal value. It is the pulmonary venous blood which will move through left heart and arrive at the arteries. So in fact, when we take a sample here, we are going to look at what the status is in pulmonary vein, which is after equilibration with the alveolus. So what we measure here is indeed this. This is true for most cases. When there is an exception, I will let you know. Now, these can be listed as respiratory causes of hypoxia, where the problem is with the respiratory apparatus. It is not able to provide enough ventilation or diffusion is impaired. But there are some non-respiratory causes where there is no lung pathology or respiratory muscle pathology or a pathology in the rib cage. Those non-respiratory causes are two. One is atmospheric hypoxia. Like in high altitude, if there is less oxygen in the atmosphere, you will have less oxygen in the alveoli and therefore less oxygen in the arteries. Atmospheric hypoxia leads to alveolar hypoxia, which is the cause for the arterial hypoxia. There is another instance where arterial hypoxia can occur even without a respiratory pathology, but that is a pathology in the circulatory system. Blood, instead of going from the right heart through the lungs into the left heart, is shunted directly without passing through the pulmonary circulation. The examples are an atrial septal defect or a ventricular septal defect. When there is an ASD or VSD, ventricular septal defect, initially because left-sided pressures are high, blood would move from the left heart to the right heart, but eventually right-sided pressures will increase and there will be a reversal of shunt. I am talking about a reversed shunt here, where blood moves from the right heart to the left heart, and I am calling that extrapulmonary because later on we will learn about a shunt within the lungs, what we call an intrapulmonary shunt or a physiological shunt. To differentiate from that, I am calling this an extrapulmonary shunt or even an anatomical shunt. In this case, though the blood that does go through the pulmonary circulation, some blood will move through the pulmonary circulation, some blood is shunted through the septal defects in the atrial septum or the ventricular septum. So, in the blood that does reach the pulmonary circulation, oxygenation will be complete, but that blood has to mix with venous blood, which is shunted, and therefore, you will have a mixture of arterial-like and venous blood here. Oxygen saturation will be lower than normal. The oxygen saturation, if you are able to take a sample from here, from the pulmonary vein, which is difficult, that will be different. It will be normal. But after the mixture, which is where we are sampling from a peripheral artery, after the mixture, PO2 and SO2 in arterial blood will be lower in extrapulmonary shunt. Yeah, that's just to say that hypoxia occurs in shunt when there is shunt reversal. Reviewing the causes of arterial hypoxia, we have two respiratory causes and two non-respiratory causes. We will use a mnemonic again, VADE. Because the vowel is there, we have to go that way. So, if you look at textbooks, in addition to these four causes, they would have added on VQ mismatch, ventilation, perfusion mismatch. Keep that term in mind. We will refer to it in detail later on. As of now, we have four causes for hypoxia. VQ mismatch will go into diffusion impairment. We will learn that later. So, we will just consider four causes of hypoxia. So, we had a mnemonic for mechanisms of tissue hypoxia, then the hypoxia or arterial hypoxia there has four mechanisms, and that is the mnemonic for that. Let us now understand the scenario in each of these causes of hypoxia. Ventilation impairment. What do we mean by ventilation impairment? What is normal ventilation? In a reference adult male at rest with a tidal volume of 500 ml, of that only 350 ml will reach the alveolus because 150 ml will be held in the space, which is not participating in gas exchange. This is all the airways, the trachea and bronchi put together. There is no gas exchange. So, of the 500 ml of air that is taken in during a normal breath in this reference male, only 350 ml reaches the alveolus, and if the normal respiratory rate is taken as 10 per minute or 12 per minute, 350 into 12 will give us nearly 4 liters of air that moves into the lung every minute and 4 liters of air that moves out as well. So, normal alveolar ventilation is about 3.5 to 4 liters per minute in a reference adult male. If the value is less than this in rest, then we would call it hypoventilation or ventilation impairment. Sometimes this person may be able to breathe in 3.5 to 4 liters per minute at rest, but during exercise conditions, the ventilation may become insufficient, and then there would be ventilation impairment during exercise. That's what we mean by ventilation impairment, where total alveolar ventilation per minute is less than normal. or less than what is required for delivering enough oxygen to tissues. Because airflow is less, renewal of the alveolar gas is less. That will lead to a reduction in alveolar oxygen because you are not getting newer air, enough of newer air. There is a reduction in alveolar oxygen, and that is what has resulted in a reduction in arterial oxygen. So, there is alveolar hypoxia in hypoventilation leading to arterial hypoxia. Because there is not enough air moving in and out, carbon dioxide expulsion is insufficient as well, and therefore there is a high alveolar carbon dioxide resulting in a high arterial carbon dioxide, what is called hypercarbia in arterial blood. So, this is the scenario in ventilatory failure. Let's summarize it. In ventilation impairment, where a person is not able to breathe in and out as required for the tissue metabolic state, there is a reduction in alveolar oxygen, there is a reduction in arterial oxygen. When you look at carbon dioxide, alveolar carbon dioxide is higher, and therefore arterial carbon dioxide is higher because carbon dioxide moves from blood to alveolus, and when the alveolar carbon dioxide is higher, arterial carbon dioxide can't go any lower than that. So, that has also increased. So, the next of the causes of the VADE, VADE is the mnemonic we used. We have considered ventilatory impairment. We are going over to A, atmospheric hypoxia. When there is atmospheric hypoxia, alveolar oxygen is lower and there is alveolar hypoxia, and that is what has resulted in arterial hypoxia. But now, this arterial hypoxia will be sensed by peripheral chemoreceptors. You might have learnt this earlier. Peripheral chemoreceptors are located in aortic bodies which are over the aorta and carotid body which is at the bifurcation of the carotid artery. That senses the level of oxygen in blood. In fact, it senses PO2, and if PO2 is low, it will stimulate the respiratory center in the brain, which will stimulate ventilation. The person will breathe more. Say you're going to a high altitude. When you go up and you face a low alveolar oxygen, a low arterial oxygen, your system will increase your ventilation. An increase in ventilation can increase the partial pressure of oxygen in alveolar gas and therefore compensate ever so slightly for the reduced oxygen in blood. However, it will be insufficient. An increase in ventilation will decrease alveolar carbon dioxide because it can blow out more carbon dioxide, and arterial carbon dioxide is therefore lower. When this has gone down, then more of carbon dioxide can move from the arterial blood to the alveolus and arterial carbon dioxide will reduce. You call this condition hypocarbia. So, now let us put this into this framework. We know what happens in ventilatory failure already. In atmospheric hypoxia, there is alveolar hypoxia, arterial hypoxia. However, carbon dioxide in the alveolus and in the artery are lower than normal, lower than 40 millimeters mercury. Carbon dioxide, the normal arterial carbon dioxide is 40 millimeters mercury. It is lower than that in atmospheric hypoxia. Let's look at the third, diffusion impairment. In this case, because there is diffusion impairment, even if alveolar oxygen is normal, there is arterial hypoxia because that normal oxygen is not able to get across sufficiently. And the hypoxia here will stimulate the respiratory center, increase ventilation. So, you might have even a higher alveolar oxygen and inevitably a lower alveolar carbon dioxide. So you're going to have a high alveolar oxygen but arterial hypoxia, alveolar hyperoxia and arterial hypoxia. Therefore, the alveolar arterial oxygen difference would be more than usual. In addition, you have a low alveolar carbon dioxide and a low arterial carbon dioxide. Please note the notation. The capital A in these terms stands for alveolar and the small a stands for arterial. So let's summarize this now. In diffusion impairment, alveolar oxygen can be higher than normal, but there is arterial hypoxia. Carbon dioxide levels are lower than normal. They are less than 40 millimeter mercury, which is the normal value. In all these three states and in the normal state, alveolar carbon dioxide is equal to arterial carbon dioxide, and that information is important. It will be used to substitute one for the other in some equations that we will be considering later on. So here already in these three conditions which can lead to hypoxia, we've seen that they can be differentiated based on alveolar gas partial pressures and arterial gas partial pressures. Let's look at the last of them, extrapulmonary shunt. Here, a sample taken from the artery will give us a low arterial oxygen. And let's look at what carbon dioxide can be like. I'll slightly change the cartoon. So I'm going to show atrial septal defect as a defect in the septum between the two atria and a ventricular septal defect here. But however, you must remember that the direction of flow of blood is from the veins to right atrium, right ventricle, and then that way. We must keep that in mind. So let's take two extrapulmonary shunts, atrial septal defect or ventricular septal defect. Let's concentrate on ventricular septal defect. In fact, this cartoon suits ventricular septal defect because the admixture of venous blood occurs here. Therefore, up to left atrium, you have bright red blood, which means oxygenation is normal. It is only beyond that, because of admixture of venous blood, you get blood that is less saturated. Oxygen saturation is less than normal because of admixture with venous blood. That's why I've shown it as a dusky color here as opposed to the bright red here. Now, in the earlier cases, a sample of blood that was taken in a peripheral artery would be the same as what you take from the pulmonary vein or the left atrium. But when there is an extrapulmonary shunt, the blood here that you sample from a peripheral artery is going to be different from the blood that actually comes from the lungs into the heart. Anyway, it is not easy to sample this. Therefore, we only have that as a clinical test. We can sample that and it is possible to make estimates of alveolar gases. So let us see what happens to arterial blood gases and alveolar gases in extrapulmonary shunt. So that's the shunt, a reversed shunt where you have a right to left shunt. So because of the admixture, there is a low PO2 and a low SO2. But what about PCO2? Is it higher than normal because of the admixture? Now, in early stages of the shunt at least, the high PCO2 will stimulate the respiratory center directly. The peripheral chemoreceptors would sense hypoxia, and if there is any increase in PCO2, that will be sensed by the central chemoreceptor itself. We will consider this later. So, both these stimuli will stimulate ventilation. Ventilation would have increased to a level where arterial PCO2 is brought back to 40 millimeters mercury. That is, alveolar PCO2 would have come down to a very low value, say 30 millimeters mercury or 35 millimeters mercury. so that in the pulmonary blood, PCO2 comes down as well, not just to 40 but to 35 or 30, so that when there is admixture of that blood with what is coming from here, you would get 40 millimeters mercury PCO2 in arterial blood. So for a very long time, even in extrapulmonary shunt, you might find a normal arterial PCO2. Only when the shunt fraction exceeds 50% of the total cardiac output, PCO2 will start going higher. Till then, the increased ventilation by creating a state of alveolar hypocarbia and therefore a hypocarbia in pulmonary venous blood, it will compensate for the high carbon dioxide that is coming from the shunted blood, and both together will lead to a level of carbon dioxide which is at 40 millimeters mercury. That should tell you that we have a very fine-tuned mechanism which maintains arterial carbon dioxide. That is just to say that the blood picture in the pulmonary vein is different from that in the artery only in extrapulmonary shunt, not in the normal case, not in the other three causes of hypoxia. In V, A and D, blood here and blood here would be similar. Okay. Now let's summarize what we just said. Alveolar oxygen is higher in extrapulmonary shunt. However, because of mixing of the shunted blood in arterial blood, there is hypoxia. There is alveolar hypocarbia because there is hyperventilation in an attempt to maintain carbon dioxide in the artery at normal level. So there can be a normal carbon dioxide, but if the shunt fraction is too high, carbon dioxide can go higher. So this is the alveolar and arterial blood gas pictures in these four states which can lead to arterial hypoxia. All of them cause arterial hypoxia. But looking at the other parameters, you could differentiate one from the other. The other big lesson is in these three states, for all practical purposes, alveolar carbon dioxide is the same as arterial carbon dioxide. The normal value is 40 millimeters mercury, and in this condition it is above 40 millimeters mercury. In these two conditions, both these values are below 40 millimeters mercury. But we are going to practically treat that both these alveolar carbon dioxide and arterial carbon dioxide are equal. It is only in extrapulmonary shunt you find that arterial carbon dioxide can be higher or be at normal 40 millimeter mercury level, whereas alveolar carbon dioxide would have gone lower than 40, and therefore one would develop an arterioalveolar carbon dioxide difference. In all other cases and in the normal condition, alveolar carbon dioxide is equal to arterial carbon dioxide for all practical purposes. That's the only condition where you get a difference between alveolar and arterial carbon dioxide. So that's the summary. We are looking at conditions where arterial hypoxia occurs, and we've tried to differentiate between the different causes of arterial hypoxia by looking at alveolar gases and arterial carbon dioxide. Now we will come to the issue of respiratory failure. Respiratory failure is a state where there is extreme arterial hypoxia. Normally we said in a reference adult male, the lowest value for arterial PO2 is about 90 millimeter mercury. And if it goes any less than that, PO2 less than 90 millimeter mercury in arterial blood would be considered hypoxia. However, only when that hypoxia is severe, we have a very precise cutoff to say what is considered as respiratory failure. Arterial PO2 less than 60 millimeter mercury is considered as respiratory failure. And why may that be? If we think of the function of the respiratory system, as to deliver enough oxygen to the tissues, then even up to a partial pressure of 60 millimeters mercury, you find that hemoglobin is well saturated, nearly 90% saturated, and therefore oxygen delivery is not a problem till 60 millimeters mercury. If arterial blood has PO2 less than 60 millimeters mercury, then you notice that hemoglobin is less and less saturated and will not be able to meet tissue demands. So anything less than 90 millimeters mercury is considered hypoxia, but only if arterial PO2 goes less than 60 millimeters mercury, you would call that respiratory failure. So in all these cases, if the reduction in PO2 is severe, going to less than 60 millimeters mercury, you would say that respiratory failure occurs. So the causes for hypoxia are also the causes for respiratory failure. Respiratory failure is severe hypoxia. We can differentiate respiratory failure based on carbon dioxide levels. If carbon dioxide is higher, we call that type 2 respiratory failure, where both gases are affected. In all these cases, carbon dioxide is actually lower than normal. Carbon dioxide expulsion is not a problem. There is a problem with only one gas. Oxygen uptake is what is reduced, while carbon dioxide expulsion is normal or even more than normal. So in these three conditions, we would say there is type 1 respiratory failure. Of course, an extrapulmonary shunt, we already saw that if the shunt fraction is more than 50% of cardiac output, carbon dioxide levels can go up. So this is one way of looking at hypoxia and respiratory failure in the oxygen hemoglobin dissociation curve. There's another way to graph type 1 and type 2 respiratory failure, and for that we will have PO2 on the x-axis, just like here. In fact, we have PaO2 on the x-axis, arterial oxygen only, and arterial carbon dioxide on the y-axis. We will learn about that line later. This is called the alveolar gas line. This actually tells us that you can have only those combinations of alveolar oxygen and alveolar carbon dioxide. A very intriguing result. We will learn about that later. Normally, if you take an arterial blood sample and estimate both oxygen and carbon dioxide in that sample, you will have values only in that region in a normal person. We already saw here that any reduction of oxygen, arterial oxygen below 60 millimeters mercury is considered respiratory failure. So we take that line. And a similar cutoff for carbon dioxide to say carbon dioxide more than this value is what we will consider as respiratory failure. Remember, we saw normal carbon dioxide was 40 millimeters mercury. Anything above 40 would be hypercarbia. Anything below 40 would be hypocarbia. Now, anything above 40 if you take, only if it goes beyond 50 millimeters mercury in arterial blood, we would say there is respiratory failure. So let us graph here. So that would be the cutoff for carbon dioxide. Carbon dioxide more than 50 millimeters mercury would be type 2 respiratory failure. So if you have your blood gas point falling anywhere here, let us say you have 50 oxygen and say 65 carbon dioxide partial pressure, then you know someone is in respiratory failure. If you have values in this range, that is carbon dioxide is lower than 50, in fact it would be much lower than 40 in type 1 failure, and oxygen is less than 60, then you call this type 1 failure. But in both these there is hypoxia because oxygen is less than 60. So this is what we call type 2 failure, and these two states where there is hypoxia but no hypercarbia, we call it type 1 failure, and an extrapulmonary shunt, it would be type 1 otherwise, but if the shunt fraction is more than 50%, it would be type 2. So we have seen 4 mechanisms of arterial hypoxia, and arterial hypoxia does not always result in tissue hypoxia. We have considered that in detail in the previous discussion. There are compensatory mechanisms which protect against tissue hypoxia in arterial hypoxia. What are those compensatory mechanisms? We saw that properties of hemoglobin itself offers a considerable degree of protection. In addition, there can be polycythemia and an increase in hemoglobin concentration when there is arterial hypoxia. There can be an increase in cardiac output, and there can be an increase in tissue extraction of oxygen, leading to a low venous oxygen saturation. These are the mechanisms that protect against tissue hypoxia in arterial hypoxia. We've considered that in the previous session. We'll take a look at it again. Let us say there is hypoxia in this individual. Oxygen, partial pressure in arterial blood is 60 or less than 60. What you notice is that hemoglobin is almost 95% saturated in this case. And in resting conditions, all that you need is an arteriovenous difference of 5 ml per 100 ml blood, and you multiply that by the normal cardiac output, you will get the VO2 that is required for resting conditions, and that is achieved fairly simply because hemoglobin is well saturated at 60. So even though there is respiratory failure and a very low partial pressure of oxygen, the property of hemoglobin ensures that there is good VO2 even in that hypoxic state. Even in exercise, we saw that an arteriovenous oxygen difference of 15 ml, which is required for the exercise state in a reference individual, can be achieved by the very property of hemoglobin itself. The curve is so steep here that it is able to achieve a good delivery of oxygen. In addition to that, we also saw that hemoglobin concentration can go up, cardiac output can go up, and tissue extraction of oxygen can go up, or venous oxygen saturation can go down, and these are the compensatory mechanisms which protect against tissue hypoxia in arterial hypoxia. Only when these mechanisms fail, hypoxic hypoxia occurs, and that is when there will be exercise limitation in tissue hypoxia. In arterial hypoxia per se, one may be able to lead a normal life as long as the compensatory mechanisms help in maintaining VO2, or the amount of oxygen that the tissues need every minute. We have seen this slide in the earlier session where we looked at a number of parameters in these 4 types of tissue hypoxia. In this session, we've taken hypoxic hypoxia and looked at other parameters in this state. So, this is the only condition where PO2 and SO2 in arterial blood is low. In all the other 3 states of tissue hypoxia, it can be normal. So, in all these mechanisms of hypoxia, PO2 and SO2 in arterial blood are low, but the other parameters can be different. Let us look at one other parameter, what we can call alveolar arterial oxygen difference. Notice that in ventilatory failure and atmospheric hypoxia, alveolar oxygen has gone lower and therefore arterial oxygen has gone lower. The difference between these two will still be normal. Both have gone down equally, and therefore the difference between the two is normal. Whereas in diffusion impairment and extrapulmonary shunt, alveolar oxygen is higher than normal and arterial oxygen is lower than normal. Therefore, the alveolar arterial oxygen difference is going to be higher. Notice that when we talk about alveolar arterial oxygen difference, we are talking about differences in partial pressures. Normally, the partial pressure of oxygen in alveolus, let us say, is 100 millimeters mercury, and in the artery in a reference adult male, let us say, is 95 millimeters mercury. The difference would be 5 millimeters mercury. In hypoxia, let us say this normal person goes hiking on a mountain, there would be atmospheric hypoxia. Let us say alveolar oxygen comes down to 80 millimeters mercury. Arterial oxygen would come down and be at 75 millimeters mercury. Therefore, the difference between the two would still be normal. Any increase in alveolar arterial oxygen difference will tell you that there is a diffusion impairment. This is diagnostic of a diffusion impairment. What I want you to notice again is that when we talk about alveolar arterial oxygen difference, we are only taking the difference in partial pressures. We've used a similar term in the previous discussion, arteriovenous oxygen difference. That term refers to the difference in content, arterial oxygen content minus venous oxygen content. So, the units for arteriovenous oxygen difference would be milliliters of oxygen per 100 milliliters blood. In fact, we would multiply that by the cardiac output to get VO2 or oxygen consumption. Please remember these two mnemonics: causes of tissue hypoxia and causes of arterial hypoxia. Thank you for your attention.